Well, cool. Yeah, well, I want to thank you guys both for coming on. Thank you, Dr. Hugo. Thank you, Dr. Knutson, for joining me today on just a little talk about, VT. Um, I know Washington University is kind of a world leader, sort of in VT or cardiac radio ablation, specifically VT, and so I'm kind of excited to hear your guys' expertise and your experience with this so far. So really quick, just to get started, I want to briefly introduce the cast of characters here since we'll have people watching. So my guests are Dr. Nels Knutson and Dr. Geoff Hugo, both medical physicists at Washington University in St. Louis. I'm Tyler Blackwell. I'm a medical physicist and I work with Radformation. I worked at a regional cancer clinic for about 10 years before transitioning to industry with Radformation, which is a group that kind of focuses on automation solutions in radiation oncology. But interestingly, I attended undergrad with one of these characters, with Nels. So we both attended the University of Montana and went through the physics circuit there together before going off to study medical physics at some other sites. So Nels, maybe you can start us off real quick, and we can come back to Geoff. But can you backfill some of your history? Where are you? Where'd you come from? What was your path, and what's your role there at WashU?
Yeah, thanks, Tyler. So Tyler and I both graduated University of Montana physics. Tyler was smart and basically went and got into grad school, and didn't know what to do, so I ended up getting a math degree, which was pretty weird. And then ended up going to LSU for grad school, and then WashU for residency. And then was lucky enough to finally end up back here for a job, and took on the chief of clinical physics just a little while ago interimly, and yeah, it's kind of where I ended up.
Yeah, that's cool. Yeah, so for the rest of the world, what Nels didn't tell you, he's got a cute little puppy named Louie, and also while we were schooling in Missoula, it was Nels that introduced me to one of his good friends, a girl named Hallie in the math department, who is now my wife. So I sort of owe Nels kind of on an ongoing basis for the rest of my life. So thanks, Nels.
Problem.
Well, in the other corner, we've got Geoff Hugo, who I know more recently from an interaction at the Winter Institute of Medical Physics in Breckenridge. That was a pretty fun conference. This one, and one of the last conferences we had, I think, before COVID struck, and we, have kind of a moratorium on these types of things. But yeah, Geoff was kind enough to offer me a buddy pass, so we spent a lot of time together on the slopes. Um, so yeah, Geoff, can you give us a little context and background for you?
Yeah. Thanks, Tyler. Well, first we should say I tried to follow you, and that didn't go so well until I got my legs under me a little bit. So, but it was a good time. Great
It was fun.
meeting, by the way. WIMP is probably one. I mean, that was my first time, and just it was a blast.
Yeah, we need to go
So,
back.
no doubt, no doubt. Hopefully, they'll have it. Yeah. So my background is in medical physics. I went to Penn State as an undergrad way before you guys graduated, and did a physics major with a medical physics minor, which was
Interesting.
actually bioengineering. Had nothing to do with radiation oncology or imaging, but it got me excited. I went to UCLA and did biomedical physics there through their grad program and did my PhD, and then kind of moved around a little bit. I was at William Beaumont for a number of years, and then Virginia Commonwealth before I ended up here at WashU about 3 years ago. And so, like Nels, I'm also in a new role. I'm the interim division director, um, and yeah, love to do research, clinic, and teaching. So, kind of all three aspects.
That's great. Yeah, so Geoff is being extremely modest. The last day at Breckenridge, he was screaming down black diamonds. So he's a pretty excellent snowboarder, actually. But yeah, very recently been doing a lot with VT here at WashU, and actually Geoff was moderating a couple talks just last week on cardiac radio ablation. He moderated two talks, as if I remember correctly. So yeah. Um, yeah, well, thanks, guys. Yeah, ultimately, what I was hoping to accomplish today was just, pull apart this topic of ventricular tachycardia, because to me, it was only brought to my attention, I think, less than a year ago, and I suspect I'm not alone with that. So naturally, as a former clinician, I want to know more about it, where it shows promise, what challenges are, what clinical implementation looks like, for those who might be interested, stuff like that. So yeah, I think just kind of starting with the basics, I admit I'm not acutely aware of what VT was or what it meant, aside from just like the branches, right? Ventricular tachycardia. So you can kind of put together a little picture that, but maybe you guys can explain, what VT is.
Tyler, you should know all about this from my talk at WIMP, man. I'm disappointed that you didn't remember every single word that I said. So,
The one great thing about the moderated talks at the AAPM Comp virtual meeting is that you can actually go back. It's all recorded. You could just go back and listen. You lose focus or attention, you can go back. You can't do that at WIMP.
yeah, that's true. Exactly. Right. And so I love that about the meeting, being able to go back and look at all the comments and things. But yeah, so VT is, I should say, ventricular tachycardia. It's a heart arrhythmia. So basically, the heart is beating too fast. What happens is it's beating so fast that the blood can't get out of the ventricle and get pumped to the body, so it can cause sudden cardiac arrest. So your blood's basically, it's not being pumped correctly. You get no circulation, and that can lead to death. So it's a very serious disease. It's interesting because in the cancer world, we talk about cancer and benign diseases. It's often classified as a benign disease. For radiation oncologists, it's not benign. It's deadly. So it's
Right.
super important to treat, and to identify. And yeah, and so radiation is one option for therapy now, or at least it's an exploratory option.
Yeah. Yeah. So, and it's pretty new to the scene. So, but why, I guess, are we just seeing radiotherapy as an option now versus the past?
Yeah, it's been around for a little bit. So there's some early first-in-man studies done at Ostrava and Stanford. But then, beyond that, there was a good number of animal studies that were done. And the concept was, one of the treatments currently is catheter ablation, where they go in with a catheter and map out where the arrhythmia is located. It's often associated with a scar, like from a heart attack, but not always. But they'll go in and map out kind of where the actual arrhythmia is arising from, and then they can burn it or something like that with this catheter. And so you're basically killing off that muscle that's causing where the arrhythmia is coming through. So the initial idea was, hey, why don't we try that with radiation? We can necrose tissue. So let's irradiate to dose and see if we can do that. So there's a good number of animal studies, and then I think the reason it's kind of in vogue now is that there's a trial or a few case series done here at WashU first, and then a phase 2 clinical trial that has good results. And so we have to give the shout out to Cliff Robinson, the radiation oncologist, Phil Kukulich, our electrophysiologist, that really took the steps and got that going here, along with a bunch of folks. So with that kind of publication of the good results there, I think people get excited about giving it a try, and hence why we're seeing people being interested.
Yeah, so it sounds like you guys kind of got one of the first starts, phase 1, phase 2 trials. Was anyone doing it coincidentally, or was it just you guys?
Well, like I said, there's a couple of case reports out there of people trying it successfully in humans, but I think here at WashU is where we started doing a trial, and people wanted to look and see what the results were like from that. With good results, then I think that gives people some assurance they can go and try it in their own clinic.
Yeah, well, I think it is a good idea on paper. You look at the just RF catheter ablation, and it looks like the results can be challenging. I think I saw somewhere between 50 to 70%. Oh geez, fail rate, or maybe it's 50% just cure rate. So they have. I think the idea is that there's just a limited success, and treating with it is kind of, well, it's invasive and it's just inherently challenging. So maybe that's why right now that there's kind of like the SBRT advantage for VT versus other existing options. So really briefly, can you just kind of describe what we're starting to see then with radio ablation?
Yeah, so I think that's a really good point. There's a couple of reasons that we'd want to look at other therapies. One is the success rate of existing therapies, the fact that many are invasive, drugs are pretty toxic, that patients go on. So, but the other thing is the size of the treatment area. Some with these catheter approaches, you can't always get where you need to. With radiation, obviously, we can get really anywhere in the heart that we need to radiate from a technical standpoint. Whether there's sensitive structures is another story. But yeah, so I think that's one of the really important aspects of it is that you can get in there, you can do it non-invasively. It's fast compared to a catheter ablation. For us in radiation oncology, it's kind of interesting because we're used to seeing the patients go in, lie down, get radiation, come out 5 minutes later. But one of the videos that our physicians often show the cardiologists is this video of the patient going into the room and then walking out. And so they're all amazed because nobody walks out of a catheter ablation. So
Right.
whereas all of our patients do. So that's, I think, a really compelling side of it, looking from the cardiology side, why they might be interested. So yeah, so now it's kind of there's a lot of people interested. We're talking to a number of sites. I don't even know how many worldwide treatments there have been to date, but certainly over 100 patients treated
Yeah.
with cardiac radioablation. We've alone, I think, talked to probably close to 40 sites just to kind of help get them started and share what we've learned, and or being very open with anybody that really wants to give it a go to really help them get started.
Yeah, right. And Geoff, I wasn't completely ignoring your talk at WIMP. I do remember the graph. I remember the graph, that showed the rise there in the number of places that are offering it. And I know that you guys have been very open with offering, all the expertise and all your experience and data, which is really cool. Yeah. So, are you guys? What's the treatment fractionation looking like right now? Is it a single fraction? Or are you guys doing multi?
Now we do single fraction, 25 gray times one. It's changed a little bit since we first started. As Geoff was saying, when we first started was we'll get, treat this really high ablative dose and cause scarring and all this stuff. And so originally we were having these like really hot plans, really heating up like an ITV core type thing. And now we've kind of backed away a little bit and are planning it more. It's still SBRT like, high doses in the middle, very conformal, rapid fall off, but maybe not, like pushing, higher doses like 35 gray to the middle or anything like that. More just more natural SBRT like
Kind of
delivery.
more homogeneous
It's
inside.
still heterogeneous for sure. It's still
It's still hot.
SBRT. But yeah, it's still hot. But it's not like we necessarily are like doing almost like an integrated boost type volume anymore. It's more just let it naturally be hot in the core and go from there.
Yeah, that sounds good. So, kind of curious, before we jump too far into talking about the treatment, but I want to talk about how we know what to treat. We have pretty good experience with, SBRT for different sites, liver, lung, spine. And for lung, for example, you can often see the lesion. You've got PET to confirm exactly where it is, and you can kind of just draw a circle. But how is VT different? Are you able to take a CT scan and see scarring, or what other data, imaging data, do we need for this?
Yeah, it's very different. There's no specific. You can't see the direct target. It's just not something you can see. So, unlike a lung tumor, like you were just mentioning. So there's really kind of 2 to maybe 3 pieces of information that are used, and 2 of them are pretty critical. One is anatomical information, like you're talking about. We often can see a scar on CT or MR or other modalities where if the patient has a scar. And so you can identify that and look at anatomically where the scar is. Then they use electrical information. So we should mention, this is electrophysiologists. This is their bread and butter, is figuring out where these arrhythmias are coming from. And so that's the person really working with radiation oncology to figure out where they want to target. So they'll use the electrical information. 12 lead ECG, or some other fancier stuff like ECG imaging, which we can talk about. But they need to use the electro information because it's an electrical arrhythmia, right? And so putting those two pieces of information together, they can identify the region they want to treat. Sometimes we use metabolic information as well, like a PET or a SPECT, to look at regions that are basically deficits in the signal that may be associated with scar or damaged heart muscle.
So then from the radiation oncology department's perspective, you guys are just kind of getting a report from electrophysiology, and they kind of provide a map of where it is.
I think it's kind of like it really is a partnership between the radiation oncologist, electrophysiologist. I mean, certainly the electrophysiologist is doing that kind of cognitive work, but you still have the core principles. We want to treat the minimum amount of tissue that we need to. We don't want to over irradiate because there's sensitive organs like the stomach or the esophagus around there, or the heart itself, right? So there's some concerns, obviously, if you irradiate too much heart. So we want to minimize. So there's still those same core principles. And then, electrophysiologists aren't typically used to drawing contours on a planning CT. So we still have a lot of partnership there where they're working together, with the radiation oncologist whose job, is to do that exact thing. So I'd say it's more of a kind of, they work together, they sit together on the computer and then, hand it off to us to figure out how to plan. So.
Well, no, I think it's cool that you guys already have that relationship kind of created. I mean, I don't know that most people have a good relationship yet, maybe with their electrophysiologists, or I mean, sometimes it's hard even to get pacemaker information from cardiologists. So I think that's always an ongoing challenge. It's just like, creating that pathway for information and collaboration. So good for you guys.
That is a side benefit. I do have a cardiologist on, I have his cell phone number now. So if I need to, get some info, we can get it pretty easily. So.
Yeah, right. You just text him at night and say, hey, what's your restaurant? What's your restaurant of choice? Where do I need to eat dinner?
There you go. There you go.
That's good.
You do learn a lot more. So it's been helpful from that standpoint. We still have, deal with pacemakers and things like that. So, but, learning a little bit more, is always good.
So okay, you get the information from them, from a different physician. They work together, the radiation oncologists, and you kind of like outline a GTV. What does it look like then from a contouring perspective? Because there's inherent challenges treating a beating heart that's positioned right in the rib cage with the lungs that move around. So I'm hoping you can maybe talk about. Well, this is a big question, guys. So sorry, I should unpack this one. But yeah, maybe you could talk about motion management and contours, ITV if there is one. What margins look like? I'll just let you guys go.
All right. I'm gonna let the master handle that one.
Nels is pointing at Geoff. Geoff's pointing at Nels.
I think the key, them working together, sort of identifying the core area where the heart, the target in the heart it was located, and everybody being in agreement to that. And then it's sort of like taking that information and translating it to like the rad-onc world that we're more used to, with a simulation, et cetera, and how we're actually going to hit it. I feel like a lot of time Geoff does his crazy wizardry behind the scenes and hands it off to me and says, okay, now go hit this ugly target that he manages to give. And they're pretty complex. I think like if you can see it in the Red Journal, some of the more complex shapes, he's like, oh yeah, this should be no problem, right? And,
Nels kicks it back.
Exactly. So I think basically, like you allude to, there's all these issues. We've come a long ways sort of in how we deal with it. I feel like to back up, when I first came back to WashU like 4 years ago, and I heard, oh, hey, we're going to treat this heart SBRT, and it's 25 gray times 1. And I was just like, what are you doing?
No, we're not.
Yeah, and I was like, okay, so that's what we do. And then I ended up being in charge of like the stereotactic program here. And so I got a lot more involved in it. And so to kind of walk you through, we treated it very similarly with like this philosophy of do not miss when we first started. And we sort of leaned on our like lung SBRT experience pretty heavily. So it's sort of all the usual suspects, 4D CT, to help, assess the motion and all this. And as you pointed out, the heart beats, right? And that's going to be in your 4D CT, the respiratory 4D CT, your lungs move, fill. So you have this motion. So we sort of started there and sort of got more and more, I guess, fancy as time went on and we learned lessons. So basically, where we would start is the 40 CT respiratory gated. We also get a cardiac gated 40 CT in the treatment position on our scanner. And we use those two. And another key thing was sort of going with the untagged recon, the average recon essentially. That's our reference image from the respiratory. And then the respiratory 40 CT. And then we get this cardiac gated one, which doesn't have respiratory motion in it, right? And we put those two together to try to assess both. So the respiratory 40 CT, obviously the patient's heart's still beating, so it has heart motion. It also has respiratory motion. And you have the cardiac gated that has respiratory only because it's done under breath hold, right?
Okay.
Uh,
So the
and
cardiac gated CT is a breath hold, and you just want to nail down what the motion is from the heartbeat. Is that correct?
Exactly. Yep. And we can look at both of them in the treatment planning system, and we sort of merge those together along with Geoff's sort of electrical information, and we can use that to just estimate our sort of motion envelope or ITV type thing. So and kind of using all that information together simultaneously, that's how we would build like a traditional ITV type thing, but assuming it's cardiac motion and respiratory. And we are getting an estimate of that basically through those two 4D CTs, and then treating like a PTV.
Cool.
So,
yeah. So the way I understand it, you're saying that you take a respiratory gated CT. So does that mean you guys are not using immobilization at all, or any compression?
Yeah, we use compression pretty routinely. We aren't using gating. We're requiring like a respiratory correlated scan, right, to get the ITV. But we haven't done any gating. I think with the abdominal compression and the other uncertainties in the process, it's we haven't at least had at our institution a patient yet where we really felt strongly that gating was needed. We've been pretty comfortable with the ITV strategy and the kind of don't miss strategy.
Yeah. Go ahead.
No, I was going to just say that, what Nels was alluding to with like the crazy targets that I provide is I'm not doing the targeting, but we've got some prototype software that lets the electrophysiologist kind of input what they're doing, and it maps it onto a model of the left ventricle that gives them some guidance on where they want to target, and then they'll clean that up to make the GTV. But it's just to kind of help them get into the frame of reference of a planning image.
Yeah.
But there's a lot of uncertainty there still. So I think, the question is like, how much benefit is it to do respiratory gating with the heart motion and all that, and not being able to really see the heart that well on, maybe fluoroscopy or something like that.
Yeah. Well, it's no, I think I think people are doing SBRT lung in a similar way. Some people treat an ITV, some people gate. So I think it just kind of, is up to the clinic to do. But you mentioned, I think UCSD, I want to say is doing a gating program. So that's kind of interesting. Listening to their talk.
Yeah. No, they've had a couple patients, I think, where talking to them with a lot of motion, right? And so then they've looked at the gating. They've got a nice gating workflow. Todd Atwood there's developed some nice stuff. So
yeah. So you said that there's a bit of uncertainty with the mapping, and I can see that really easily. How you may have some physiological information, some some imaging data, but then so there seems to be a bit of uncertainty. So I know you're drawing an ITV, but what kind of margins are you putting on for that ITV, or are you comfortable just putting on typical stereotactic like a 5 mm margin?
I think it's kind of multiple piece too. So the ITV, it's not exactly like a lung tumor where you clearly see it move in this envelope. Instead, we're looking at two different studies that have different motions, and sort of estimating what we think is a reasonable safety envelope of that motion, granted, plus the GTV uncertainties in that as well. And then we sort of handle the PTV margin. We try to handle it separately, sort of, like it really is the setup uncertainties and all that. So I think it depends on how you're doing it. I think when we very first started doing this, or when Cliff did before I got back here, they were doing it on a true beam, no sixth off couch. This is pre-average, being average scan being the reference, all sorts of stuff. And so we slowly kind of like fine tune that process to now we use sixth off couch, alignment to the average scan, on like a modern true beam, edge stereotactic unit and stuff. And so kind of tweaking that down.
Okay.
But largely it's kind of been a very much building a comfort zone and fine tuning.
Yeah. No, it sounds like you guys are doing a Linac-based treatment.
Yeah.
Yeah, great. Yeah, I mean, if you're doing it on edge, you've got some small leaves there in the center. Using 6FFF.
Yep.
Okay. Yeah. Yeah. What else does treatment look like? How are you guys imaging? How are you guys, setting up?
Yeah. So we do basically, it's kind of evolved, but the basic idea is to use like a 3-arc template with like 15-degree couch kicks, so a 15 and 345 couch, and then 0. And we've sort of adopted from those 3 5 half arc template. So it's just like a 1 up, 1 down on each of the 15-degree couch kicks and a single one at 0. And yeah, 6FFF. We have our sort of optimization stuff down to a pretty fine science. And because a lot of the times we try to get these plans turned around as fast as possible. The patient's not, doing well with this VT and stuff, and we really want to get them in and out of here as fast as we can.
Yeah.
Yeah. So the treatments are fairly straightforward. We do, CBCT guided. I think probably the biggest advancement, I remember going from like a helical reference scan to an average scan is pretty huge, because like when you cone beam them, their heart's beating, obviously they're breathing. So your cone beam scan is always this blurry silhouette of the heart. And if you were using like a fast helical scan, then you have like the snapshot of the heart versus this blurry heart.
Right.
And it's like, well, where do I match all that? So the matching with the average has been really helpful. The sixth off is helpful, but again, like we do like a pretty stereotactic, similar alignment or and setup compared to like our long SBRTs. So full SBRT immobilization with compression and all that stuff. And
yeah,
that really helps. And basically do that, align to the cardiac silhouette, soft tissue.
Okay.
And fluoro to ensure that with motion everything is sort of lining up what we would expect.
Yeah. Just do a quick fluoro once you're lined up. So you cone beam shift, do a little fluoro.
Yeah, with the AP lateral.
That's cool.
Treat.
Any y'all don't use fiducials? You said you're aligning just to the heart.
Yeah, I mean there are like cardiac leads and stuff, but you'll note that the target doesn't necessarily correlate with those, and they can be pretty distant at times. So we tend not to track off of that or anything. I know.
Yeah, it's a good thing to note that I've seen or have heard that leads, you think, well, that looks like a fiducial, it's metal, right? We can easily match to that better than soft tissue perhaps, but yeah, I've heard that maybe it's not a good surrogate, or maybe like a good rough surrogate for motion, but maybe not for localization. I don't know if you have a comment on that, Geoff.
Yeah, I think you got to, the short answer is it depends, right? So it depends where it is, as Nels said. We've got a study, one of our residents, Mike Crusader, has done a study. He's going to present at Astra on this. And it's, you got to keep in mind that the lead that goes down in the ventricle is often in the right ventricle, and it's in healthy heart muscle, right? Because it needs to be electrically active, because you're pacing through that, or they're sending a signal through it. So it can't be in the scar and the dead tissue where we're treating. So depending on the size of the scar and the location, it may or may not be in a good spot to use. Some of the CyberKnife folks have actually put like an inert lead and and mounted it near the target to use as a surrogate. So that's a strategy that's been used before. Yeah.
Okay. Well, go ahead, Nels.
I was gonna say, yeah, like Geoff's saying, it totally depends. Like if you just watch some fluoros of some patients, you can see how complex the lead motion can be sometimes, versus just a nice soup inf motion that we're used to, sort of like gating a liver case with fiducials, where it's like, oh yeah, they're breathing up, down, nice and easy. These can just be crazy trajectories and stuff, and
I
pretty
can imagine.
complicated. They're just like, oh, I'll just gate on the lead. It'll be no problem. It really is a, patient selection type thing. And kind of, I think, sort of, we really want to get the full process down pat before we investigated any sort of, gating and stuff
Yeah.
like that.
Have you guys had patients that you rejected because there was too much motion? Have you gone there
I
yet?
don't, no. But again, we're not trying to gate, like, and I would say, yeah, I don't think we've had any that we've just turned
Okay.
away.
Yeah. That's kind of cool. Yeah. So yeah, one quick treatment and then they're out, waving on the way out, right? That's pretty cool. That's got to feel really good.
Most of them. Some of the sick ones have to be wheeled out, but
Yeah. Well, I think it's
wheeled
great.
in and wheeled out.
Yeah, because I mean the data I've seen, I think Geoff, with your talk and with Dr. Robinson's papers, shows really dramatic reduction. Comparing the previous 6 months tachycardia rates versus the following 6 months, and even I think you guys even have a little bit more longitudinal data that's showing that yeah, even over the next couple of years, you see a really big reduction, more than just 50 to 70% or whatever. So
Right.
that
Yeah. Cliff's reported at Astro some longer term, and the results are pretty durable. The patients seems to hold at least as far out as we've looked so far. So the nice thing is, with the all these patients have an ICD implanted, a defibrillator, right? So they that's measuring basically if they go into tachycardia or not. And
right.
so you have that nice outcome data. You can measure beforehand, you can measure after, and there's some subtleties to it, but in terms of like getting you some immediate feedback how well the treatment did, it's really nice to have that.
I'm glad you brought up the pacemaker because I wanted to ask about that. I mean, you're treating the heart, for goodness sake. Have you guys run into any issues keeping dose down, or what have you encountered with respect to that pacer?
Yeah. So I can only think of one case out of all of them that we altered our template, our planning template, and we removed one of the soup to inf arcs, or that part of the template. And basically, it was just a pretty strange placement of the ICD. It was a lot closer than normal. But most of the time, in like that standard placement, we haven't had any issue. It's usually really easy. I mean, with the 5 arcs with couch kicks, the fall off is really fast.
Yeah.
And typically we can avoid, dosing the pacemaker pretty
Okay.
well. And we use it as well,
Yeah.
just to, minimize risk or anything.
Yeah, if you think about where the can, the where the electronics are that you're worried about,
right.
it's usually up here, right? And so it's more like a breast treatment where you'd be concerned about giving dose to that
Right.
than, where we're treating with the heart. But there's some questions. It's interesting. Some people have asked us about treating the lead tips, because, that's an area where, like I said, the lead to function correctly needs to be in healthy heart muscles. So if you irradiated that, would you do some damage? We haven't seen anything like that, but it's an interesting question. Should we put some constraints on that or not? And so, I don't know. I think it's to be seen.
Yeah, I'm not aware. I mean, when I was in the clinic, I don't think we really paid that close of attention to those. Even when we were treating, really adjacent lung, and you're treating to, 70 gray or something like that. So it's the same with SBRT. Sometimes you get SBRT lung, rather, where you could be potentially really close to those leads.
Right.
So you guys have done quite a bit. How many patients have you treated so far? Do you know?
I think it's let's see, maybe 41 now, Nels.
Something like that.
41, 42, something like that. I mean, I know we treated 40, and then we've had 1 or 2 since then. So
That's really cool.
yeah.
Yeah. So, what kind of studies are you doing now, for future WashU or for future patients that, and yeah, so I know you guys have made it this far, and you guys have been working on this, investigating it for a number of years, and you've already seen some really good initial success. So where do you see this going for you guys then in the next 12 months, 24 months?
Yeah, that's a great question. I mean, besides the physics studies we're talking about with like looking at motion and some things like that we're interested in, I mean, the main thing is to move this into like a multi-institutional trial. I think that's the big push. So we've been looking at different means to do that and kind of exploring how we're going to do it and designing this, what the trial would look like. But to the smaller study that has shown that it has potential, but now we have to show that it's robust and it can go in the community, and we can get it out to other institutions and all do it similarly and get the same results. So that's the crucial next step in my mind, would be looking at just cardiac radioablation and how we might assess that in multi-institutional. Beyond that, I mean, there's all kinds of things that could be done. You could look at questions like, is the dose right? It should be, lower. Probably doesn't need to be higher, but perhaps in certain cases it might need to be. Could it be lowered? I think looking at like comparison with other treatment modalities, people are always interested in those kind of maybe phase 3 studies or something, head to head against something else. And then are there other populations of patients? Because we're treating quite sick patients right now. They've really run out of options. They've maybe failed catheter ablation, or they're not eligible for it for some reason. And so, they've been referred to us for that. So, the question is that the right population, or the other
Sure.
populations that could benefit? So
Sure.
Lots of interesting questions. Yeah.
Yeah. So, right. Yeah, so you mentioned a good point. So you're currently treating people that, patients that have failed RF ablation, catheter ablation. So, I mean, or do you envision this could be actually an alternative to that in the future?
Oh gosh, I don't know. I mean, that's a good question, probably for like the electrophysiologists.
Crystal
And
ball, Geoff.
yeah, I mean, it's hard to say, but I think it's certainly, and the way we've looked at it in the patients we're treating, it's my impression is it's used more right now as, like you said, like a salvage therapy for patients that have failed, or they just, for whatever reason, they're contraindicated to getting another therapy. So that's what the focus is now, and who knows what the future may hold. But
Yeah.
Possibly. I mean, I don't know.
I've got kind of an oddball question for you guys, maybe a challenge. So, was there anything in the past few years that you tried, either just through any part of the process that just didn't work out, that just failed, and then you had to kind of reassess and readdress? Anything that pops to mind?
I mean,
Yeah.
I've tried some image registration. I think that was the main thing that drove us to this prototype software. It was like, oh, the easy thing is we've got an cardiac MRI scan and a cardiac CT scan, and then the 4D cardiac gated scan and the 4D respiratory. Let's like merge all this, because I'm an image registration guy. So it's like, let's register everything. Let's register this ECGI imaging, and we'll get like a really nice thing. The cardiologist can flip back and forth and draw the target directly in the treatment planning system. But it's really challenging to do that. The image quality is hard. The patient's either in breath hold in one scan and they're free breathing in another, and there's artifact and all that. So we kind of abandoned that strategy pretty quickly. That's my failure right there. But maybe Nels has something else. It sounds.
Well, Nels did. He's an all-star undergrad. I know he didn't fail anything quite like I did, but maybe maybe he's got something there. What do you got, Nels?
Yeah, so thinking that like the cardiac 4D and the respiratory 4D would give us like the traditional, I'll just follow this thing around and draw an ITV, like that was a pretty epic failure. It's more I mean, it's not a failure, but it's difficult.
Right. We're learning, right? We don't fail, we just learn what not to do.
Right. I think it's more of an educational tool, and really helps like estimate, I would say, sort of like a little bit of the uncertainty in the motion envelope, and it's more of a guide than it's never going to be like a perfect registration between those two 4Ds to allow you to just do the traditional, I'll just trace the motion envelope, because
Yeah.
really, really impossible. So like I said, the cardiac 4D is done under breath hold. So how do you have the patient hold their breath? Do you do it on exhale, inhale?
Sure.
What's the plan, right? So I think the first one we did was, DIBH, and we're like, holy, that didn't work at all, because most people don't spend their average time on inhale, it turns out. So then we tried exhale, and it's similar issues, and we've sort of settled on this mid exhale, like blow half your breath out and hold
Yeah.
it, and
Oh, that's what you're currently doing now?
yeah, we've sort of went through these iterations, yeah, and it's still not ever going to be perfect. So it's more of just like a informational tool, and it's super helpful, I think. And you can kind of see these cases where, like, for a given patient, maybe the respiratory and cardiac component combined versus the cardiac component alone are really not that much different. So it would be hard to argue gating would be a good in that case, right? For instance, or maybe the cardiac motion is just very complex. So,
Yeah.
Good. I think the other big, huge thing that I learned was, OARs, like, we spend so much the beginning time focusing on targeting and don't miss, and realizing that the OARs move too, like especially the stomach is super key for some of the targets. Some of the targets can be very stomach adjacent, and sort of adopting that kind of the reverse strategy of PRVs, and really thinking about the robustness of your plan. What's the worst case scenario if the stomach changes, or if stuff like that. So converting isodose lines the day of, and really having that, like, do not cross threshold line has been super helpful. Which
Okay.
actually, some of the feedback we got from other groups that started doing this were like, oh man, what you're doing is really scary. We were going to definitely do this. And I was like, oh, that's a great idea. And yeah, so using tools like that and just really learning each case, has been really eye-opening. Great.
Yeah. Well, it's good to know that, none of these trajectories are straight lines, that they kind of, curve around and back and forth a little bit. Yeah. Yeah. I know we didn't really touch on OARs, but it's kind of cool. It sounds like, so thanks for touching on it, but it sounds like the stomach, especially being, being so sensitive, being so close to that inferior portion of the heart, that would be a big one. And if you're delivering 25 gray, that could be a pretty hot spot for, for the stomach.
Right.
So, yeah.
Yeah, I think stomach, esophagus, and then the heart itself, right? The substructures like coronary arteries, or aspects of it that we're
Okay.
concerned about. I mean, these very sick patients, they may end up getting like a heart transplant, or we may just be kind of palliating, and they may not last, end up living very long. And I guess then the question is for them, the trade-off the physicians have to make is um, their quality of life, and like reducing this arrhythmia, which is really just debilitating now, versus heart dose. Whereas maybe if we're looking at healthier younger patients, there may be different considerations there, but certainly things like stomach are always a concern if the target's nearby.
So you mentioned substructures. Are you contouring all the substructures for the heart for this?
Not for like optimization. We have done a pretty good series of retrospective contouring and looking at all this, but not for like optimization.
Gotcha.
We contour the heart, and sort of we have like the heart minus ITV type structure that we use all the time. It's really important. When we first started, like a lot of people would say, oh, you can just make an SBRT fast fall off plan, and the NTO will handle it and all this. And we found that it was really advantageous to hammer that, and really get the dose to the uninvolved heart as low as possible. And some targets are much easier than others. Some are like more peripheral. So obviously you can spare the heart minus ITV easier than if it's central. But yeah, we always try to minimize that. And I would say like our drivers are basically like conformity, the fall off, making as fast as possible, and then sparing as much, normal heart, and then the OARs, of course, would always win out.
Yeah.
PRVs type thing.
Cool. Well, I mean, is there some? I feel like we got a pretty good impression of what you guys are doing at WashU. I've asked a lot of questions to poke holes, or rather, just to really figure out what you guys are doing, start to finish, and so I appreciate the explanation on everything VT. I think it's really cool. I think it's sort of a hot topic right now, where people have been introduced to it just at the last few meetings and conferences, and people are looking for more information. So thanks for sitting with me to do this. But if you are okay with it, I feel like I want to hear a little bit about St. Louis too. I want to get a St. Louis flavor. If you guys want to answer a couple questions for me that are not
Yeah.
related at all to VT.
No, shoot.
Okay. Well, so you were mentioning that you got physicians' phone numbers. Well, I've got your guys' phone numbers too. So let's say I'm going to go to St. Louis and I want like the best grub. I want like the best food ever. So I want you to think about like what's your go-to? What's your favorite meal, St. Louis?
This is a good way to start a fist fight in St. Louis. Is like, what's your favorite barbecue, or what's the best barbecue joint in St. Louis, right? So
Yeah.
be careful what you ask.
Oh, so
Nels,
Geoff,
you've lived here
you're a
longer.
barbecue guy.
What I do love my barbecue. I gotta say, I'm a big fan. There's some good ones around here, but I gotta think of my favorite. So there's also, it's like a best versus proximity,
Right. Yeah.
and there's a pretty good one called Salt and Smoke that they just put a second one in right up the road, and we can walk there from the hospital. So that's always a good one.
Are you a brisket guy, Geoff?
I grew up in Arkansas, Mississippi, so I'm kind of that, like, I don't know, pulled pork, but I do like a good brisket as well. Just none of that North Carolina stuff.
Okay.
That's
Yeah,
not my
I
style.
wish I could be there. If I go, I'll be getting barbecue because there's a bit of a dearth. There's a dearth of places up here in the Pacific Northwest. Barbecue is not the forte up here.
You can find your fair share of barbecue
Yeah.
in the St. Louis area. So
What about you, Nels?
Yeah, there's so many in St. Louis. It's great. St. Louis is a really awesome city. It's a little weird in this pandemic, but I definitely love Happy's. It's right next to a brewery that is like hockey themed. It's pretty great. It's called Center Ice. They're connected. There's also a chicken joint in there called Southern. And it's like spicy chicken, barbecue, and beer. So you
It's
can't
like a
really go.
co-op kind of thing.
No, I don't know. It's I guess an old building that sort of got taken over piece by piece, and those were the three awesome businesses that ended up in there. Yeah, I love the breweries here. There's so many awesome breweries. Forehand, Civil Life, Second Shift. They're all great.
Geoff is nodding. He's like,
yeah.
Yeah, Narrow Gauge, all of them, just awesome.
Can't leave out Narrow Gauge. That's
Basically, I have our satellite clinics mapped out by brewery.
If I've got to go to this place, if I've got to go to this satellite for clinical duty, I've got to visit X.
What can I, go and make sure I can bring home a 6-pack from wherever, and it's always super fun.
Yeah, right.
Yeah, when I'm heading up to Alton, I'm like, all right, take orders at Narrow Gauge because it's pretty far up there, but it's well worth the trip. So
fill up the growler.
Yeah, exactly.
A 45-minute drive for most of us.
So. All right. Yeah. So I'll pivot to a landmark question. So we all know about the arch. So let's exclude the arch from this conversation. But what do you think is, like, I don't know, the coolest other landmark in St. Louis? What's a place
easy.
You want to go to? Okay.
That's an easy one. It's got to be Forest Park. I mean, we've got this beautiful, huge park just right next to the hospital. And I remember when I was, interviewing here, and you just hop out of the hotel and you can go for a run around there, and it's gorgeous. There's all kinds of stuff. There's a free zoo there. There's an art museum that's free. It's all free to enter. So it's really cool park.
Tower Grove Park is also really awesome. I live 2 blocks from it. It's another just huge. St. Louis is a great city of parks, and there's just tons of them that are big, and yeah, I definitely love that. And actually the Missouri Botanical Garden here is pretty incredible too.
Okay. You guys must work a lot of hours because you're in the department so much. What you guys really appreciate are the parks. You get outside, and then it's like a big thing. I think I visited the zoo. I went to Purdue for undergrad, which is in West Lafayette, Indiana, and I can't remember. Maybe it's 4 hours away. So so we visited St. Louis really briefly, and I think I remember going to a free zoo. So that's probably what you were referencing, Jeff.
Yeah, that would be it.
Cool. Well, wait. What else? What else is there, Nels? You've got more to say.
Yeah, the Blues Arena is pretty awesome. You can see where the Stanley Cup was won. That was pretty great. Downtown.
When was that St. Louis won the Stanley Cup, Nels? Do you remember?
The champions.
Yeah, that's right. Okay.
Haven't lost it. Still the champions. And like City Park downtown's really cool. It connects sort of like all the way from the Arch down like most of Market Street, and it's just like a bunch of green space right in the middle of downtown. So you'll be like around tall buildings, and then this really nice green space in the middle. Mm-hmm. Goes past the Blues Arena and the Cardinals Arena. And all that.
You guys are making me want to go there. Maybe we should. Yeah, can we advocate to AAPM that we need to set up an annual meeting there?
There you go. Well, we got our SNORAD meeting, which is the Symposium of Non-Invasive Radioablation Cardiac. Basically, so we're doing that once a year. Although I think we're planning to maybe move it out of St. Louis, just get a little bit different place. But we've done some meetings, so
yeah. So that's a new meeting that you guys have created. Just
we did it. We've done it 2 years now in St. Louis, and it was just probably 200 people or so from around the globe interested in cardiac radioablation came and just shared ideas, talked about what they're doing, patients they're treating, and studies they're doing. And then we're gonna plan to have it in the fall here in Europe, but it's going to be postponed as everything is. So
yeah, we'll come out of it sometime. Conferences in the future, we'll all warmly embrace. We'll all it'll be good to kind of share a cold one with everyone and just reconnect for sure. Well, I want to respect you guys' time, but I want to thank you guys both again for taking the time to share with me. I mean, I'm scratching my own itch. I'm really kind of curious about VT, and just really interested and really happy that I know both of you and can reach out to you guys. I know that if I had a clinic that was interested, you are the two that I would reach out to and get all the details. So yeah, thank you so much for your time here today.
Yeah, thanks, Tyler. It was a lot of fun. Appreciate the opportunity to chat with you.
Yeah, cool.
That was a blast, Tyler.
All right, we'll do it again another time. All right, see you guys.
Sounds good. All right, take care.